utilize the Q&A function located on the bottom ribbon of your screen. To do so, we'll be tracking those questions and we'll go through those at that time towards the end of the presentation. Again, afterwards, we'll have our informal meet and greet. So straight to what we're doing for the day. Very excited to have Dr. Marilyn Rubidoux with us here today. And I'm going to turn it over to her. I'll stop sharing now to introduce herself and get started with today's topic. Thank you all for being here. All right, Dr. Rubidoux, it's all yours.
Well, hi, everyone. I'm delighted to be with you today. Using Zoom is always an adventure as to whether it's going to work and how things are going to be. Anyway, so we'll keep our fingers crossed. Today, I'm going to be talking about breast cancer among American Indian and Alaska Native women and lung cancer among the same population. And then at the very end, a tiny sort of advertisement about a cervical cancer project, which is not mine, but it's starting up here at Michigan that I think would be of interest to people because it's a home cervical cancer screening test. And doing things at home is always easier than running down to the hospital, right? Okay. As a disclosure, I am on the board of directors of the American Indian Clinic of Detroit. So let me ask Guthrie one question for a minute. Up at the top of my screen on my computer, it has all that stuff for a Zoom, like mute, video, participants, chat, and stuff, which kind of gets in the way of me seeing my titles, but I don't know that there's a way to move that Zoom thing. Do you know what I'm talking about? It's where it's the black thing that has participants, chat, you are screen sharing, stuff like that.
Yep, go ahead and I think you can minimize all of those windows.
Oh, well, I moved it down to the bottom.
Okay.
So
whatever you got to do to be able to see.
I'm okay, because I can see the top of my slides now, which I was having trouble seeing the top of the slides. So this thing is now down at kind of the inferior edge of the slide, so it's not bothering me anymore.
Okay.
All right. The next thing I was going to tell you all is that I'm on the board of directors of the Detroit American Indian Health and Family Services Clinic, which is an urban American Indian clinic that provides medical care and traditional native healing, as well as behavioral health practice instruction, spiritual practices. We have sweat lodges over there in Detroit about approximately every other month, and they are really, really hot. Just because it's Detroit, it's not cold. And they also have a lot of interesting wellness and behavioral health activities. So it's been very interesting to participate in this urban American Indian clinic and see how things operate and work there, which work really, really well. Okay, on to the next. How do I go to the next slide? Oops. Oops, that did it. Okay, sorry. My mouse, yes. As for me, I'm a member of the Iowa Tribe of Kansas and Nebraska. This is a reservation that's in northeastern Kansas. We have a powwow every year in that location. There's another Iowa tribe, which is in Oklahoma, but they are two separate tribes because they split in 1890 over whatever sort of differences there were at that time. But anyway, that's my genetic connection to American Indian heritage. And so next thing, then I was going to tell you this bear claw necklace up here in the right corner is a tribal necklace that is quite famous, the bear claw necklace. And interestingly, when I came to Detroit, first came here, I wasn't born and raised here. I was born and raised in Idaho. But when I came to Detroit in 1991, I went to the art museum down in Detroit, and I'm wandering around looking at stuff, and all of a sudden I see this spectacular bear claw necklace, and it says it's the Iowa tribe necklace. And I'm thinking, that's funny that it's in the Detroit Institute of the Arts. So later on, it turned out that the museum did not know that that bear claw necklace was inappropriately there. It had been sold to the museum in 1945 or something like that, and someone made a lot of money from selling that necklace to the museum. So that got repatriated back to the tribe, fortunately, when it was discovered where it actually was. I've been a radiologist since 1991. I went to medical school at the University of Utah and did my residency at Duke University in North Carolina, which are two cultural places that are so completely different that I might as well have been in two different foreign countries. Ha ha ha. I wish you could hear, I could hear you laughing. And then I came here to Michigan in 1991. I finished med school in 1984. I came here with my husband, who we came on faculty at the University of Michigan Health System Department of Radiology, where I started doing radiology and mostly breast imaging full-time. And this is an image of our hospital situation here in Ann Arbor. The main thing about Ann Arbor is actually the football stadium, not the hospital. The football stadium is a huge, big deal. And everything else is relatively smaller and less important, including the hospital, as compared to the football stadium. So also, as I said, after I came to Michigan, I joined the board of directors for the Urban Indian Clinic in Detroit. It's called the American Indian Health and Family Services Clinic. This serves the largest population of Indians in the East. Michigan has 57,000 Native Americans, and they come from 100 different tribes. So not all Michigan tribes, but predominantly Michigan tribes, of which there are 12 tribes in Michigan. So let's go back a little bit farther about when I tried to figure out how, as a radiologist working at an academic medical center, what in the world could I do to improve healthcare among American Indians who were not necessarily urban American Indians, because they're taken care of by the urban clinic, but American Indians more in rural areas. And I myself, coming from Idaho, had come from a rural area where we had the Bannock Shoshone tribe very close to Pocatello, where I grew up, and I was used to being around rural American Indians. So I heard about this outreach project that the College of Pathology was putting on in a breast and cervical cancer detection project in South Dakota. I signed up for this, and we went to 2 clinics, a bunch of people, pathologists and a few radiologists, to the McLaughlin Clinic, if you know where that is, and the Rosebud Hospital. And I did mammograms while the other physicians and healthcare workers who came along, they did pap smears, cervical cancer screening. So here I am back in the days when radiologists had to have a magnifying glass to look at mammograms in the clinic. And this was rewarding and interesting beginning to my interest in serving in American Indian healthcare activities. Subsequently to that, I met at a National American Association of Indian Physicians meeting a wonderful woman from Mayo Clinic who ought to be pretty famous there, named Judith Cower. And she had already been starting to work in American Indian outreach activities and other work. And she started a a group of an organization called the Spirit of Eagles is what we ended up calling ourselves. And Judith was the leader of that group for many years, ever since, I guess, about 2003 up until she retired a few years ago, and is now in Florida and might even be on this thing that we're talking about today. So maybe she'll jump in and talk later about her retirement and how wonderful it's going in Florida. So this is Judith, who started the Spirit of Eagles work, which was to implement small group Native projects in various places on any reservations or among Native people to study topics and improve outcomes in healthcare. So that's Judith Cower of Mayo Clinic. And here I am when I was about 20 years younger. Another activity that I engaged in was with the help of Linda B., that's who she's called, Linda Byrne-Stepanoff, who has worked so much in American Indian outreach activities. With her help, we designed some culturally relevant breast cancer electronic education. That means computer. When I say electronic, I mean these are computer things for educational methods to teach American Indian and Alaska Native people about breast health issues. And so we designed this as kind of a computer. It's not really a game, but it's an educational thing. And also we made a breast care bingo, or you could play bingo on the computer, and a breast cancer detective game. So these are electronic games that she and I made. And if anyone is interested in seeing them more obviously, contact me and I can send you a copy of those educational, they're sort of a game, but it's more like an educational thing that you do on a computer. So, and it's especially targeted to Native American women. So the next thing that happened was, because of the Spirit of Eagles, I heard about the idea that there was a mobile mammogram that had been designed at Johns Hopkins over in, not Native territory, but in the East. Johns Hopkins had designed this mobile mammography unit with the idea that it could be implemented into the Great Plains Indian Health Service, or in fact, anywhere where there were rural areas that had disparities in access to mammography, because you can put mammogram equipment on a truck and drive it around and recruit patients and do their mammograms in that truck. So this is what happened. It started around 2005, and it kept going until 2017, and the Great Plains Indian Health Service operated the truck and the personnel on the truck, and I was the lead interpreting physician to make sure that the mammograms got done and got read properly. The mammograms were initially transmitted by satellite from South Dakota to University of Michigan. And we did that for the first couple of years. But then what happened was the satellite transmission method became too expensive. They charged too much money for sending the mammograms that way. So ultimately the mammograms got sent on CD from the mobile unit in South Dakota to University of Michigan. So I read those mammograms from 2005 to 2017. And it was a great thing because patients would record when was the last time they had a mammogram when they came onto this mobile health unit. And very commonly, they had either never had a mammogram or their last mammogram was 3, 4, or 5 years ago. And as you know, mammograms should be done every year if you're going to catch breast cancer early. So that was a great service that went up until 2017, and it could have gone on longer, but it was discontinued because of the fact that the Great Plains Health Service could not hire truck drivers because at that time they were in such great demand. They couldn't get truck drivers. They could get nurses and technologists to work on, to be on the truck and to serve patients, but they couldn't get truck drivers. So that was the end of the Great Plains Indian Health Service mobile mammography unit. And it was a beautiful thing. And here is more or less what it did. It went all over the Great Plains Indian Health Service to every facility, every medical facility in that region, and did mammograms, and they recruited patients into the truck to get them done. That was 8 reservations and 18 clinics, as I said there. And here was a testimonial. I don't know if it will win or not. Yes. Okay, so happy customer, yay. Now, this wasn't actually the first mobile mammography unit. In New Mexico, a friend radiologist colleague of mine, Mike Lindber of Santa Fe, started a mobile mammography unit early in the 1990s, and this served all of the tribes of New Mexico, not just part of them, but all of them. And this was a pretty heroic effort, I thought, because this was before the days of digital mammography. It was the days of film mammograms. And this was a successful outreach effort. And the only reason that it was discontinued, again, had to do with money and a new regulation that came down from the state that every patient had to have a physical exam when they got their mammogram, which is kind of crazy. So that kind of put the end on that project that he was doing, but that was initially very successful. So let me tell you about breast cancer now. A breast is actually a life-threatening object. As you know, there are 48,000 annual deaths for cars, guns, or breasts. You didn't know that a breast was as dangerous as a gun, but it is, because cancer is dangerous, and if you don't have early detection, it's going to be something that can kill you. So this is why we work hard to screen for breast cancer in women, so that it won't be like your own personal gun. Breast imaging is more limited for patients to access than chest x-rays or CT scans, which I'm sure you're wondering, that's strange. Of course, you're there at Mayo Clinic, you have no trouble running in and getting your mammogram any old time, right? Well, mammograms are kind of limited to get once you're outside of an urban area. And why is this? The reason is that there was a law passed in 1991-ish that required FDA accreditation for mammography equipment, radiologists, and technologists. So this is the FDA. The FDA are those same people who study your drugs and approve your drugs and approve other medical equipment. But the FDA is not involved in anything else in radiology. It doesn't supervise chest x-rays. It doesn't supervise CT scans or anything else. No, they took it upon themselves to decide to worry about mammography. And so there's very complicated laws and regulations that have to do with mammograms, the equipment, the radiologists, the technologists, all of these things are inspected every year by the FDA, and we have to pass those inspections or we can't operate mammogram units. And there are many mammogram facilities that fail the inspections and can't continue to operate. So, and there's a long backstory about how this happened. Why is mammography the only medical imaging test that is supervised by the FDA? Well, it actually has to do with long ago when mammograms were done in the 1980s, and they were pretty crappy mammograms, not very good quality. And there was an expose on 60 Minutes by Diane Sawyer, who exposed these horrible mammograms. And it happened that the head of the FDA was watching 60 Minutes, the TV show that night, and he said, oh, to himself, I guess, he said to himself, oh, that's a terrible thing. The FDA has to fix that. So that was the beginning of more complications for mammography. So because of the FDA laws, only FDA certified technologists and FDA certified radiologists can perform and interpret mammograms. That's a federal law. I guess it sounds like I'm complaining a little bit, but it's only because this is the only part of radiology that has the FDA involved in it. The FDA is normally just involved in your drugs, right? Not your x-rays. That didn't show up. So now let's talk about American Indians and Alaska Natives and the breast cancer disparities and gaps. First of all, more Native people, women, are diagnosed with breast cancer at, sorry, oops, I wanted to go backwards and I couldn't do that. Differs, yeah, all right. Anyway, surgical treatment disparities exist at certain places. So there are some places where you need to get surgery, but it's too far away because of rural locations. And lumpectomies are less likely to be done than mastectomies, and lumpectomies are preferred because there's less access to radiation therapy in rural areas. So if you're going to get a lumpectomy, and you have a small breast cancer, that's all good, but you do have to get radiation therapy, not just the lumpectomy. So if you live in a rural area and access to radiation therapy treatment is far away, then it's not practical for a patient to have to drive a long ways several times a week to be able to get their radiation therapy. There are people who are working on this problem to hope to make lumpectomy more available to rural women, but it hasn't quite completed that, that accomplishment yet. So another thing that's a disparity is screening mammograms have been lower in American Indian and Alaska Native patients than among other races. And this really kind of has to do with rural locations, and then also lack of sometimes awareness or recruitment into mammography. But all of this has gotten much better in the last 20 years. So a lot more mammography is going on now than ever happened previously. Another interesting thing is that breast cancer incidence actually differs by race. So for example, in the last 25 years, the incidence of breast cancer, believe it or not, decreased 0.6% in non-Hispanic women. So you would hope that you'd see the same thing in American Indian women, a decrease in breast cancer. But on the other hand, it didn't. Statistically, the breast cancer rate increased among American Indian and Alaska Native women, 0.9%. So that's a substantial difference from what has been happening in the rest of the population. There are other breast cancer disparities. American Indian and Alaska Native women are diagnosed at younger age. 30% of breast cancer cases occur prior to age 50 in non-Hispanic women, and in American Indian, Alaska Native women also have later stages than non-Hispanic women have. The mammogram screening rates are lowest in Native women compared to other ethnic groups, and a lot of that has to do with rural areas and disparities in access to mammograms in rural areas. So programs are still needed to increase equity in screening for Native women. The mortality rates among Native women since the 1990s haven't changed. They haven't gotten better, whereas mortality rates in breast cancer have gotten better for white and Black women. There are also treatment disparities in as much as there are fewer lumpectomies, partially due to this thing of distance with travel, as I talked about. So there's more mastectomies. There are also higher stage tumors among American Indians of the Northern Plains if you compare to white women in that same area. The incidence of breast cancer in American Indians varies by geographic location. So we'll get to another graph that demonstrates that for you. For all American Indian women, travel times are about twice as long as anyone else in America, and an average sometimes of more than 50 miles. So long travel times can delay diagnosis and treatment of breast cancer. Now here's a nice graph. This came from Judith Cower at Mayo Clinic, who made this very nice graph that demonstrates that there is regional geographic variability in the incidence of breast cancer, but only among American Indian and Alaska Native women. So look at the gray bars here. The gray bars are non-Hispanic white women, and you'll see that the incidence rate of breast cancer is about the same for all of them, no matter where they live, Alaska, East, Southern Plains, Pacific Coast, all the same for non-Hispanic white women mostly. But for American Indian women, this is very peculiar. In the Southwest, they have a lower rate of breast cancer, about less than half that of American Indian women in the Southern Plains, and less than those in Alaska. And then, so it's very peculiar that the incidence of breast cancer varies by geography in Native women. And no one's been able to quite explain exactly what is going on here, whether it's genetics or whether it's environment or whether it's patient habits and practices. We don't know, but that needs additional study. There are also disparities in breast cancer treatment. Ideally, if you got breast cancer, you want to get early stage or stage 1 or 2 breast cancers. Those are small. And if you have cancer that is like that, you should be able to get lumpectomy with radiation, which is the most commonly accepted treatment for early stage cancers. However, American Indian women, even with these small of cancers, still have more mastectomies than non-Hispanic white women. 41% have mastectomies versus 34% of white women. And this may and likely may be due to the fact that it's hard to get radiation therapy in rural areas, or you have to drive a really long ways if you live in a rural area to get to a place that has radiation therapy. And then that's a barrier because maybe the roads are bad, maybe the weather is bad, maybe your car doesn't always work. It's hard to reliably get somewhere every multiple days in a week for radiation therapy when you live in a rural area. Now, it's intuitive, and you probably all know that to prevent death from a breast cancer, what you really need is early detection. And early detection only occurs if you're having screening. You can't wait until you have a lump. That might be too late for effective early detection. So screening with annual mammograms is recommended to start at age 40 nowadays. And if there's a strong family history risk or genetic risk, you should start your mammogram sooner. Furthermore, if breasts are what's called dense on a mammogram, and we'll get to that point later, everybody's breast doesn't look like everybody else's breast. They're all really different. If you have dense breasts, then you may also need to have ultrasound. And if you have high risk in terms of lots of family history, who have had breast cancer, then you probably need to get screening MRI as well as mammograms. Now, mobile mammography has been useful for underserved women in many places, even in urban areas. Mobile mammography has been useful for underserved inner city women. Mobile mammography increases access. It's cost-effective in both urban and rural environments. And many patients who come to mobile units are uninsured or have low annual household income. And it delivers the services in a woman's own neighborhood, which is pretty nice. This was like, the mobile unit of the Indian Health Service in the Great Plains area. Now, as I told you, every woman's breast is really kind of different from anyone else. There's no one normal. And this is what makes reading mammograms a challenge, because if you look at chest x-rays, they pretty much all look exactly alike. They don't look different from each other much at all. But on mammograms, they're dramatically different from patient to patient. So they're even more different than fingerprints. And that makes reading mammograms more challenging. There are no harms of screening mammography, so that's good. You can get your mammogram. It's a tiny radiation dose that has no effect on your life. But mammography is not perfect because about 1/4 of cancers are not visible on a mammogram. So it's a good test, but it's not perfect. So physical exam still hasn't gone away because of the fact that mammograms don't find all cancers. So physical exam and breast ultrasound and MRI are the other things that can be used to bridge the gap of the fact that mammograms don't show all cancers. And if you include these other things, then you can detect cancers that are invisible on a mammogram. Now, screening disparities vary by geographic area, unlike other races. And I'm speaking about American Indians, because the screening disparities are more difficult if you are not close to a region that has a mammography facility. Breast cancer death rates dropped in other racial groups in 1990, but this has never happened among American Indian and Alaska Native women. There are higher American Indian breast cancer death rates in the northern and southern plains, like I showed you on that graph from Judith Keller's work, and Alaska than Southwest. So breast cancer rates are low in the Southwest, but higher in Alaska, the northern plains, and the southern plains, as shown in those other graphs. American Indian women have a greater chance of stage 3 breast cancer, which is not a good stage. That's where the cancer has gotten out of the breast and into the lymph nodes. And if less than 50 years, have about 1.5 times a higher risk of invasive breast cancer as compared to non-Hispanic white women. So we also have shown that breast cancer incidence has increased in Alaska Native and American Indian women. It increased 8% in these years and decreased 10% in non-Hispanic white women. That's just the presence of cancer, or the rate or risk of cancer. And these incidence rates were higher in the northern plains, southern plains, and Alaska. Now, here's another disparity that's interesting. This is young women relatively young women. Their age is less than 50 years. These are minority women and American Indian women. And the graph demonstrates that death rates are higher. This is the purple one here. Death rates from breast cancer are higher in Native American women than they are in non-Hispanic white women. And this is like almost twice as high, but not quite. And why this is, no one exactly knows, but this fact was just published. If you can read the reference down here by Ed Hendrick in 2021. So this is not an old statistic. This is current to times now. So that means it's very important to get screening to Native American women, especially who have any risk factors, and especially starting at age 40 at the least. Don't wait till age 50. And just as I said just now, recommendations to start mammograms at age 50 are too late for some, especially American Indian and Alaskan Native women and African American women. So here we have non-Hispanic women who had breast cancer between 2014 and 2018. 15% had it at age less than 50, but it was a higher rate than that of American Indian women at 22% that had cancer prior to age 50. So this has been really important because the guidelines for when do you get mammography have traditionally been, up until this year, get mammography starting at age 50. Well, here's the thing. If you don't start mammography to age 50, you might be too late to catch the breast cancer early. So this year, the U.S. Preventive Task Force Services changed their recommendation to be age 40 instead of 50, which was really kind of a big deal and good. Similarly, in Michigan, a third of cases of invasive disease in American Indian women occurred at age less than 50. So if you're not screening until you're 50 years old, you've already missed a third of cancer cases. So this is why radiologists in recent guidelines say we need to start screening at age 40, not at age 50. Other disparities among American Indians are that even in early stage breast cancer, more mastectomies are occurring than in white women, and they have been less likely to be treated with lumpectomy, which is a kinder, gentler treatment than mastectomy, among Northern Plains and Alaska women than white women. American Indian and Alaska Natives in the Northern Plains, Alaska, and Southern Plains have higher rates of late-stage cancers versus the non-Hispanic women living in the same locations. Now, this is just published. This is not old news. This is current news. So we have to be on top of this. There are also regional disparities in surgical treatment because mastectomy versus lumpectomy. It's better to have a lumpectomy if you can, but you can only get lumpectomy if you have early stage disease. But even if you have early stage disease, some women, some American Indian women have been getting mastectomies, such as in the Northern Plains. Mastectomies were done for 49% of American Indian women versus 35% of non-Hispanic women, and also same statistic in Alaska. And these are disparities in breast conservation for American Indian and Alaska Native women. And there's the references there if you want to look them up. And they're new. These are not old. This is 2022. Now, these are the locations and density by color of our indigenous populations in the United States. It looks like there aren't any in New York City, although there must be a few. But as you know, the reservations are located in these areas, in these locations is where the indigenous women live. And I tried to overlay this map, which is access to breast imaging facilities and travel times to mammography, over the other map. So keep an eye on any of the reservations you might be interested in or know about. And we'll see if this works. So light blue means it's a long travel time. Dark blue means it's a short travel time. And as you can see, long travel times are predominant in areas of where American Indians live. And that's one of the reasons that we have disparities in healthcare and in breast cancer, because it takes people longer to drive somewhere to go be seen for that lump. And this is a similar graph demonstrating that. This is American Indian women. This thing right here demonstrates travel time to mammography or MRI. This is mammography, this is MRI. Takes 84 minutes for a Native American woman to get somewhere to get her MRI in this study. So death rates of breast cancer have decreased in other racial groups since 1990, but not among American Indian and Alaska Native women. There are higher death rates from breast cancer in American Indian women in the northern and southern plains and Alaska as compared to the southwestern United States, which has lower rates of cancer and death. American Indian women and Alaska Native women less than 50 years have about 1.5 times higher risk of invasive breast cancer. Invasive means that's the cancer that spreads elsewhere in your body, or it may spread elsewhere in your body if it's invasive, as compared to non-Hispanic women. Invasive breast cancer is the more dangerous type of a breast cancer. And ideally, when you get a mammogram and there's something abnormal on it, you will hope that when they biopsy it, it's not an invasive breast cancer, but it's a non-invasive breast cancer. But you have to catch those non-invasive cancers early, and that's why we do mammography, right? In the northern plains, southern plains, and Alaska, American Indians and Alaska Natives have about 1.5 times higher risk of late breast cancer, which is unfortunate as well. Now, the average distance to mammography screening, as calculated by this article published in JACR just this last year, 2023, said the average distance to mammogram screening for Native women is 44 miles, or 0.2. In other words, this person lived right next door to the clinic, I guess, to 198 miles. 198 miles is a pretty long ways to go for your mammogram, I have to say. So distance is a barrier, and people need to think about how to deal with this problem as well, so that it's not prohibiting women from getting the breast care that they need. Poverty and rurality were associated with less access to cancer screening among American Indian and Alaska Native tribes. And of course, their conclusion in this article is that increasing mobile cancer screening would improve access. And there has been, over the last 10 years, increased use of mobile screening for reservations. We have been seeing that, but there could still be more. Now, for saving lives in breast cancer, your greatest tool is annual screening mammography beginning at, it should be age 40. And if you have a family history of breast cancer, it should be sooner, it should be earlier than that. The caveat is that mammograms show most, but not all breast cancers, and about 20 to 40% of cancers are actually not visible on mammogram. So for women who are at high risk, they need additional imaging by ultrasound and MRI, because MRI, unlike mammograms, show 95% of cancers. And that's really useful for women who are at high risk of breast cancer to have MRIs every year. But those are not cheap. Those are expensive, or you have to have good insurance. Now I want to tell you a little bit about what's called mammogram density. The thing is, every breast does not look like every other breast. Every breast is almost like a fingerprint. You could make them as fingerprints, and you could identify women just based on their mammograms, because mammograms are so different between people. They're more different than even fingerprints. So look at this. Here's this. All of these are patients who have a breast cancer. Here's that breast cancer. It's easy to see why, because of the rest of the breast is dark and the cancer is white, right? Here's another breast cancer in here, not so easy to see. Or maybe it's even hallucinatory. Maybe that's not even a breast cancer. Or is that a breast cancer? That's tough, right? What's the white tissue? Is that normal or is that cancer? And then on this patient over here, you can't even see the cancer at all in any way, shape, or form. It's like a seagull in a cloudy sky. You can't see it. But if a seagull is in a blue sky, you can see it super easy. Well, that's the thing about mammogram density. If you have what's called dense breasts, that means it's hard to see what's in it. Now, when should you start getting screening? They used to say start at age 50. And now the U.S. Preventive Task Force Services is saying start at 40, because that provides the greatest benefit to women and the least risk for examination. The U.S. Preventive Task Force Services new guidelines say start at age 40, which is brand new compared to their previous guidelines, which was age 50. And guidelines may also be altered based on patient risk factors. How much risk does the patient have, especially in family history risk? Here are other ways we can look at the breast. We got MRI, ultrasound, tomosynthesis. As you know, travel times can be a barrier. So if you have to go a long ways to get your MRI, that's a deterrent. And there's often no insurance coverage for supplemental screenings with ultrasound or MRI beyond mammogram screening. So patients must pay out of pocket sometimes for not routine screening. Now, I was going to show you when I was running the mobile unit of the Great Plains Health Service. At first visit to the mobile unit, 60% of the women had had no prior mammogram in the previous 2 years. And I think we're doing better than that nowadays on the reservations. The women have been getting their mammograms, and there's not such a mammogram desert. Actions to address disparities in breast cancer. So mobile mammography is great. That's super helpful to get women to get their screening. This is in Michigan. This is the Bay Mills Indian Community Reservation Mobile Unit. Here's where Bay Mills is, up and beyond the regular part of Michigan in the UP. Mobile units are great for improving access. And I already told you this, the dense breast, it was harder to see the cancer in a dense breast. It's like clutter. You can't see the abnormalities. They're hidden behind all this stuff. Really, breast MRI is the most sensitive and accurate test, but since it's so expensive, access is very limited. About half of women have dense breasts, and this is a problem for mammogram to detect cancer in dense breast mammograms. Like, there's actually cancer right here, but you can barely see it, right? This is not a problem for MRI. As you can see on MRI, it's easy to see where that cancer is right there. So MRI is really good for finding cancer. It's just unfortunate that it's expensive. Majority of women live within 30 minutes of mammography or ultrasound, but there's big MRI gaps in rural areas. Additionally, if you miss one mammogram screening, that will increase the mortality rate statistically if you do get a breast cancer. So every year is the right thing to do. 2 missed screening exams doubles your mortality rate from breast cancer. A missed mammogram screening exam correlates with higher stage of breast cancer at detection. So don't miss those annual screenings. And there's still gaps that have to do with race, ethnicity, and being in a rural area. Advanced imaging access is hard to get in rural areas as compared to urban locations, where it's much easier to get MRIs, for example. Now, here are some quick facts about mammography. I don't think I have time to run through all of those, but if you get a copy of this talk, you can see them. The tough thing about mammography is every woman's breast is different from everybody else's breast. So that makes it a challenge. Mammograms are like fingerprints, but we do the best that we can. And we have a lot of technology to help us. We also want to recruit underrepresented students from groups who struggle with health disparities. This is a student who came to Michigan for his master's degree, and I got him involved in mammography. And he's now at Johns Hopkins and getting his PhD in public health, which is great. I think now I'm probably going to skip a little bit of lung cancer because we talked so much about breast cancer already, and you already know that lung cancer is pretty deadly and how different it is by regions. With some regions, such as southwestern United States of American Indians, hardly any lung cancer there, whereas the northern and southern plains and Alaska having a lot of lung cancer. Low-dose chest CT screening is important to be able to detect lung cancer. And if you have people in your family who smoke, they should get, or who have smoked, they would benefit from CT lung cancer screening so you can catch the cancer early. All right, now the last thing I wanted to tell you, this isn't related to mammography at all, but why is this computer doing that? Okay, I have a colleague named Diane Harper here at Michigan who has developed a home cervical cancer screening test. If anybody wanted to not have to go to the doctor's office and get their cervical cancer screening done there, she has developed a thing for doing it at home. And she's looking for a home test especially great for disabled patients so that they don't have to come out to the doctor's office. They can do the test at home for cervical cancer. And if any of you are interested in this particular totally different topic, I'll put you in touch with Diane, who can enroll you or your patients in some of her clinical trials for her home-based cervical cancer screening study. There you go. That's her email. You can just email her directly and ask her about it. And that's the end. I made it. Okay. Thank you for listening. I hope you're listening. I hope you're listening.
Thank you so much, Dr. Rubidoux. That was awesome. We have a few questions. Let me
Great.
see if quickly, can you go back one slide, and then I can put Dr. Harper's email in the chat if folks are interested in connecting with her. Thank you.
Great idea. Great idea.
Okay. All right. All right. Okay, so that's there. Let me bounce over to the questions. And folks, real quickly, so things are a little bit different this month. Let me see if I can. Do you want to stop sharing your screen, Dr. Rubidoux? I think if you just
Stop video.
no. Oh,
No.
wrong one. Here, hold
What do I
on.
need?
I got it.
Which
Don't
one?
even worry about it. I'm gonna do it.
Stop share. Okay.
There we go. I'm sharing just for a moment. I'm gonna stop share. Okay. All right. Perfect. Now people should just be able to see you and me, which is fantastic. We can't see them, which is unfortunate. And guys, I'm trying to figure out what the best way is to have more time for informal Q&A. What we'll do here real quick is I want to do a couple of things and we'll break into questions. So before folks who have to leave at the top of the hour, um, thank you for joining us. We are going to continue on here in the same space for the next 30 minutes or until everyone drops off. We are going to be taking a break in September from having an Indigenous Health Topics. We're going to be joined by Dr. Rodney Herring, who was on one of the slides that Dr. Rubidoux just presented at the beginning. If you'd like to join us for that discussion, I don't have a topic yet, but you can add your name to the registration using that link right there. Additionally, if you're looking at a screen and want to scan the QR code, you can do so doing that, but I'm going to drop the survey in the chat here as well. Okay, so with those kind of housekeeping items out of the way, I'm going to stop sharing and I'm going to jump to the questions that we have. First of all, thank you so much. I thought that was a wonderful presentation and super informative. It's been a long time since I've had something this focused on cancer in Native patients. So it was really great to just center and think about Native people as we're relating it to cancer topics. And so one of the questions that was in the Q&A chat came from CP Provost. They're wondering, they want to go back to school for becoming a radiology tech, looking at different options for education, wondering which might be the best route, whether it be a community college or a technical school as the options that they're looking at right now. Wondering if you have any opinions about where to go to be a rad tech.
I would say a community college. Your biggest and best accessible community college.
Oh, you know what? Well, thanks for answering. It looks like CP hopped off at the top of the hour, but I agree. Dr. Cower, who is on the call, she asked one, before I get to hers, because hers will be a little bit, Brandon Alkire, who's from my tribe and serves within the state apparatus here in Minnesota, is wondering if we can get a copy of the slide deck.
Sure.
Okay, I will share that out with anybody who's interested. Please let me know and I can I can send that to you, but I'll definitely make sure, Brandon, that you get that. Lastly, Dr. Cower is wondering if you could please share a little bit more about molecular breast imaging as a new tool.
Yeah, I didn't talk about that. You're right. It hasn't really seemingly caught on as much as the other things. It's probably more accurate than, it seems to be more accurate than just mammograms by themselves. They're often doing mammograms and molecular breast imaging both, because as I showed you, mammography isn't fail-safe. And molecular breast imaging does find the cancers that mammography doesn't. But it seems to be, like in my area, there isn't even a molecular breast imaging facility unless you drive down to Toledo, which is about an hour and a half away. So I agree that molecular breast imaging can be an adjunct to mammography, but it's also not the be all and end all, but it's an accessory to help you make sure you're not missing anything, especially if you have dense breasts. And the good thing about that technique is, unlike MRI, it doesn't cost you an arm and a leg, and your insurance may cover molecular breast imaging and not agree to cover a breast MRI. So I think that's a good option, but you still need to get your mammograms as well.
Okay, real quick, just since we are at the top of the hour, I did, one is Dr. Cower's on. I've provided her the opportunity to unmute if she would like and speak. I'm going to stop the recording right now and we're going to be done with the webinar, but we'll continue on with question and answer. Folks, if you have questions or would like to speak, please raise your hand and then I will allow you to unmute and you can just ask your question or continue to pop them in the chat. But I'm going to stop recording right now. hopefully that gives us a little bit more of a